Hey guys, we're going to be doing drugs for women's reproductive health and menopause. Yippee. Okay. All right, so brief overview of the menstrual cycle. So the average menstrual cycle for a woman is 28 days, but we know that women, everyone's different, so that may sway a few days either early or late depending on a woman's cycle and their individual body. So the hormones mostly that we're going to be looking at when we're talking about altering a woman's menstrual cycle is progesterone and estrogen. But we also have luteinizing hormone and follicle stimulating hormone. All right. So you'll notice that estrogen levels rise quite sharply right before ovulation, and then they drop down, and then progesterone levels increase. Following up until about 4 or 5 days prior to menstruation. Okay? All right, so some effects of estrogen and progesterone. I got this from a British site, so some of the spellings might be a little funky. All right, so estrogen stimulates breast cysts and increases body fat storage, salt and fluid retention. It can impair blood sugar control and decreases libido. Progesterone protects against breast cysts and helps use fat for energy and keeps it off the hips. It's a natural diuretic. So just take a look at, I'm not going to read each one, but make sure you read the effects of estrogen and progesterone. So when we're all augmenting or giving additional estrogen and progesterone to people, we have risks of, things like headache. We increase their risk for blood clots and so forth. So we have all types of birth control methods, right? We have condom, the female condom, pill, hormonal rings, intrauterine devices, injections, surgical sterilization, implants, coitus interruptus, or the old pulling out method, calendar rhythm method, which does work if a woman has a regular cycle, the patch, and a diaphragm. But this is a pharmacology class, so we're really going to be looking at medications, okay? All right, so how do oral contraceptives work? So a lot of them are a combination of estrogen and progestin, which is artificial progesterone. And both estrogen and progestin prevent eggs from being released from the ovaries. So no egg released, no chance of pregnancy. Progestin causes thinning of the endometrium, which prevents implantation of a fertilized egg. And it also thickens the mucus in the cervix, which prevents sperm from reaching the eggs in the first place. Okay. So types of hormones in oral products. So estrogen. The one that you're going to see is ethinyl estradiol, or EE. It's most commonly used. It's and then we also have mestranol, which is converted into EE once it's in the body, and it's used in higher dose products. But almost everything we see on the market today has ethinyl estradiol in it. And then we have progestin. So the big one is the norethindrone. There's also the levonorgestrel, or the LNG. And then we have drospirenone, which is derived from spironolactone. So that particular one can affect potassium levels just like spironolactone can. So combination oral contraceptives. So combination oral contraceptives contain a combination of synthetic estrogen and progestin. And together they inhibit ovulation. And remember, progestin also thins out the endometrium and thickens the mucus. So they come in 21-day or 28-day packs. So they're either 21 days of active pills and then 7 placebos. Or people just remember that they don't take it for a week. All right. And what happens is you get withdrawal bleeding or a period. Now we have newer guidelines that allow for extended use or continuous, meaning that people can skip their monthly bleeding, their menses, and they can have 4 or less periods per year. There's also something called the mini pill, which contains only progestin, such as norethindrone. It thins the endometrium, it thickens cervical mucus, it decreases fallopian tube peristalsis, and may prevent ovulation in about 50% of patients. And that one's taken continuously without a break. This one has a strict 3-hour window, so you have to take it at the same time every single day. Same time every single day. And an example would be the Micronor, that's the brand name, which is 0.35 milligrams of norethindrone. Other combined oral contraceptive products, and the next slide, we use this more than any other thing, right? Combined oral contraceptives. So the pill is the most easy contraceptive to use. If used correctly, it has a high degree of effectiveness and it's relatively safe. And when these pills first came out, the doses were much higher, until we realized that we could, get down to much lower doses. And with a lower dose, you still have high efficacy, but you don't have the side effects. All right, so the combined oral contraceptives reduce the risk of developing ovarian and endometrial cancers, pelvic inflammatory disease, breast and ovarian cysts, and osteoporosis. Barrier or abstinence, other methods of birth control, should be used when switching products. So your doctor says, you know what, this product is causing some side effects. We're going to switch you to another type. During that switchover period, you could have ovulation, so a barrier or abstinence should be used. Or if they're on antibiotics, antibiotic use will oftentimes end up with an accidental ovulation. So make sure if the patient is on antibiotics, they're using a barrier method, okay? And there's an herbal alert in your chapter as well. So they're differentiated based on the strength of the estrogen, the type of progestin, and whether or not the estrogen or progesterone and androgen activity predominate. So there are literally hundreds of different types of oral contraceptives on the market nowadays. Too many to list and for you guys to memorize. But what they do does change. So there's the monophasic, which means the same doses in every active pill. So every single pill you take all month is the same dose of the EE and of the progestin. There's biphasic, meaning the EE dose is unchanged, but the progestin dose changes during the cycle, and this allows for normal menstruation without ovulation. There's triphasic, so the amount of the EE or progestin varies throughout the cycle in different ratios. It allows for times of the month where they don't have to have as high of a hormone dose, has fewer side effects, and includes less breakthrough bleeding. So a little more complicated. And then there's the four-phasic, which is the newest type. All right, so now we have a patch, Ortho Evra transdermal patch. It contains EE and a progestin, norethylgestrinolmin, or CHC. Okay. The patch is placed once a week for 3 weeks in a row. So you have to kind of remember so that's something that you put on your calendar, like every Monday you're going to put on a new patch. The 4th week is patch free to allow for withdrawal bleeding, and it's very similar to oral contraceptive pills by inhibiting ovulation, thickening cervical mucus, and so forth. And it's the same health benefits of oral contraceptives. Now we have the NuvaRing transvaginal contraception, and this contains EE and ethnogestrel, which is a progesterone. So it's a 2-inch diameter flexible indwelling ring inserted into the vagina and goes up near the cervix. It's non-biodegradable, transparent, and colorless, or almost colorless. And you remove the ring 3 weeks after you put it in for withdrawal bleeding, and then you put in a new ring. Okay. If the ring falls out, it can be rinsed off and reinserted, but it has to be done within 3 hours. Within 3 hours. If you go and you realize you woke up and this thing's been out for 8 hours, you need to talk to your doc and come up with another method of contraception until you get back on your schedule, because you are at risk for ovulation and pregnancy. Depo-Provera. This is a nice one, especially for you get a teen mom that's come in and delivered and you want to prevent at least pregnancy for a few months after delivery. It's highly effective, long-acting, injectable progestin. It's in the form of depo-medroxyprogesterone acetate, or DMPA or MPA. Causes, it stops ovulation, and it stops menses, so they don't have a period either. It's 97 to 99% effective, so very effective. Doses are scheduled every 11 to 13 weeks. What's nice is this is safe to use immediately postpartum, and it doesn't affect milk production. So if we have a mom that's just delivered a baby and she wants to go back on something, we can actually give this while they're still in the hospital. It is a progestin without an estrogen product. So long term, it can affect bone density. So we tell women, all women who are of childbearing age should take calcium supplements. But we make sure that these ladies take calcium supplements and participate in weight-bearing exercises. Remember, in order to build bone, you need to participate in weight-bearing exercise. So, something to consider. And then we have implantable progestins. So you can have the Nexplanon, which is a single rod device that contains progestin with the etanogestrel. So it's actually implanted underneath the skin. So it lasts for 3 years. It's 99.6% effective, though it may not be as effective in obese women. The more body fat you have, the more natural estrogen you have in your body. This one also has issues with implantation errors, so you need to make sure that the provider that's putting this in knows what they're doing. We also have intrauterine devices, or IUDs, and these can, the Mirena is the most common product nowadays. It lasts up to 5 years, and there's also the Paragard. So the Mirena has a very low dose of progesterone, 20 micrograms per day, and the Paragard has copper in it, and it does not have hormones. Okay, so there is a difference between the two. So the Mirena is used way more commonly than the Paragard. So Mirena can make periods go away altogether, and it does make them much lighter or shorter. But we're putting a foreign device into a woman's body, so there is an increased risk of infection or pelvic inflammatory disease from insertion. Also, for women that are, with the Mirena, may not be using a barrier device, with thinking, well, I'm not at risk for pregnancy, and they forget that they are at higher risk for pelvic inflammatory disease. So they can catch something from their partner and end up with an infection. All right. There is a risk for the device dislodging or being expelled. There will be either a coil or a string that the patient is taught to feel for. So they would place their finger into the vagina and feel for the coil or the string to make sure it's still in place. And the Mirena is sometimes used to control heavy periods or decrease perimenopausal bleeding. So it's not unusual for someone in their 40s who's having increased perimenopausal bleeding to have a Mirena placed just for the progesterone effects and having a little lighter periods. So start date and dosing schedule. So depending on the provider, so first day start method. With the first day, the contraception product is initiated on the first day of menstruation, or the first day a woman experiences bleeding. Depo and NuvaRing should use this method. Okay. Then there's the Sunday start. So patients start the tablets or patch on the Sunday after the first day of menstruation. If menstruation actually starts on a Sunday, the patient starts her tablet or patch on that day. And then there's quick start, meaning they start the same day you get the prescription, regardless of when they are in their menstrual cycle. This one increases patient compliance and resolves the risk of becoming pregnant while waiting for this thing to actually start working. And then we have other methods of contraception. We have spermicides and barrier methods. So condoms, female condoms, and diaphragms are barrier methods. And most should be used with a spermicide. Now we have emergency contraception, or EC. Usually the common one is an extra dose of a oral contraceptive pill, such as Plan B. And also, Paragard, the IUD with the copper in it, can actually be inserted within, I think it's 2 days. It's in your textbook, but can be inserted. So if they've had, a night out, or there's a rape, or something, non-voluntary sex or a broken condom, they can go to their provider the next day and have a Paragard placed, and that prevents implantation of the egg. Or they can do something like a Plan B or a high dose of oral contraceptive pills to prevent implantation. All right, so we're giving people, estrogen supplementation and progestin supplementation. And then we're also going to talk about loss of that when we deal with menopause. So excess estrogen can cause nausea, vomiting, dizziness, fluid retention, edema, breast tenderness or enlargement, cholasma, which is that mask of pregnancy, leg cramps, decreased estrogen, which is what happens when people start to go through menopause, can have painful sexual intercourse. They can have vaginal bleeding, breakthrough, which means they're not bleeding with their normal cycle. They're just bleeding, at weird times. Oligomenorrhea, very scant periods, nervousness, excess progestin, increased appetite, weight gain, oily skin, acne. You can also have yeast infections. Decreased progestin, you can have dysmenorrhea or a heavy menstrual flow with clots, and then changes in laboratory values, including thyroid and liver function. So menopause. It's a transitional process experienced by women as they move from the reproductive years into the non-reproductive stage of life. Usually happens in the mid to late 40s to mid 50s, though some women have it later than that. Perimenopause is that 7 to 10 year period while women are transitioning through this. And then we have menopause, the actual cessation of periods for a year, and postmenopause is the time after that. So common symptoms are hot flashes, which is caused by a surge in LH levels, and vaginal dryness caused by estrogen withdrawal. So we have premenopause, cramps, anxiety, mood swings, perimenopause, mood swings and hot flashes, night sweats, vaginal dryness. Menopause, again, is that cessation of spontaneous menstruation for a year. And during that time, they can have hot flashes and night sweats, loss of libido. And then postmenopause, because we've lost that protective mechanism of estrogen, there's a higher risk of certain conditions like osteoporosis, coronary artery disease, and urinary tract infections. So we do have hormone therapy. There are women that opt not to go through all the fun stuff that goes along with menopause. They're having serious hot flashes or vaginal dryness. So you can do an estrogen progestin therapy for use for women who have an intact uterus, or just estrogen for women who've had a hysterectomy. Postmenopause, it's the stage when the body adapts to new hormonal environment, right? And over a period of years, the estrogen and progesterone from the ovaries decreases. So hormone therapy does help vasomotor symptoms and, like the hot flashes and vaginal dryness, and it does decrease the risk of osteoporosis and osteoporotic fractures. Okay, but hormone replacement therapy should only be used for the treatment of menopausal symptoms at the lowest dose possible for the shortest duration possible, usually less than 5 years. If women have a risk of ovarian or breast cancer, they may be advised not to use this. So, contraindications to hormone therapy include pregnancy, a history of endometrial cancer, personal history of breast cancer, history of thromboembolic disorders like a blood clot, acute liver disease, active gallbladder or pancreatic disease, coronary artery disease, undiagnosed vaginal bleeding, and endometriosis. So some other things that we can give for menopausal symptoms is an SSRI. So we can give them depression medication, or clonidine, or gabapentin.